Good day, everyone. The topic for today's discussion is an overview of CNS vascular malformation. These are the learning objectives. This section will introduce CNS vascular malformation, focusing on the definition and classification using the International Society for the Study of Vascular Anomalies. One will be able to differentiate common types such as the arteriovenous malformations, cavernous malformations, and venous malformations. We'll also explore their clinical presentations, potential complications, and the neuroimaging features essential for diagnosis. Vascular malformations are also known as angiomas. They are non-cancerous clusters of abnormally formed or excess blood vessels, arteries, veins, capillaries, or a mix, resulting from disrupted embryologic development and primitive vascular pattern persistence, often with altered blood flow dynamics. They are congenital anomalies or blood vessels in the brain or spinal cord, involving arteries, veins, or capillaries. Though often asymptomatic, they may cause symptoms later due to rupture, thrombosis, or mass effect. This slide outlines the major types of cerebral vascular malformation in the CNS. The most clinically significant are the arteriovenous malformations, which poses a high risk of hemorrhage. Cavernomas may bleed or cause seizures. The vein of Valley malformations, typically seen in infants, are rare but serious, often lead to high output heart failure. When typically benign, cerebrovascular malformation can lead to complications such as headache, prostatitis, or hemorrhage. They often affect the head and neck and have genetic origins involving disrupted vascular signaling and may coexist with other congenital anomalies. Multidisciplinary care is essential, and understanding their molecular basis helps to guide diagnosis, classification, and targeted therapies. CNS vascular malformation accounts for 4 to 5 to 9% of intracranial space occupying lesions and 20 to 40% of surgically treated brain hemorrhages. Most of them are located in the cerebral hemisphere, with few found in the deep brain structures such as the basal ganglia, internal capsule and choroid plexuses, and the posterior fossa. Vascular development occurs in distinct phases. First is vasculogenesis, where blood vessels form de novo from mesenchymal precursor cells. Next is angiogenesis, during which these primitive vessels remodeled and differentiate into matured arteries and veins. Cerebrovascular malformations result from defects in early angiogenesis, particularly between 4 to 10 weeks of gestation, leading to abnormal vessel structure and function. The International Society for the Study of Vascular Anomalies classify vascular anomalies into tumors and malformations. The vascular malformations are further divided into 4 types. The simple, which consists of single vessels type, like the venous malformation, arteriovenous malformations. Then the combined, which involve multiple vessel types, like arteriovenous malformations combined with venous malformations. Then those associated with syndromes, like Sturge-Weber syndromes, the Clovis syndromes. Then the major artery malformations, those affecting large arteries or veins, for example, the vein of Galli malformations, even aneurysm, fall under this category. This system of classification aids in diagnosis, understanding pathophysiology, and guiding treatment strategies for CNS and systemic vascular malformations. The International Society for the Study of Vascular Anomalies classification system is used globally by clinicians, researchers, and radiologists to improve the management of the patient with these malformations. These are some of the syndromes associated with CNS vascular malformations. CNS malformations can also be classified based on the flow dynamics into low flow and high flow types. The low flow lesions include capillary, venous, and lymphatic malformations, which lack arterial components and exhibit slow circulation. High flow lesions involve arteriovenous malformations and fistulas, where direct artery to vein connections result in fast blood flow and high pressure shunting. Clinical presentation depends on the type of lesion, the size, the location, and the flow dynamics. High flow lesions like arteriovenous malformations often present acutely with hemorrhage, intracerebral hemorrhage, while low flow malformations may remain silent or cause gradual symptoms. Common presentations include seizures, headaches, focal deficit, hydrocephalus, or mass effect. It is important to look out for systemic signs like skin lesions or congenital anomalies, especially in syndromic conditions like Sturge-Weber syndromes. CNS vascular malformation can lead to serious complications. Hemorrhagic events include subarachnoid hemorrhage, spontaneous intracerebral hemorrhages, and rarely epidural hematoma or hematomyelia. Compression of neural structures may cause cord or spinal symptoms. Systemic complications arise from venous thrombosis, drainage issues of vascular seal. Over time, chronic vascular insufficiency may result in progressive radiculomyelopathy, such as Fox-Alajuane syndrome. Prompt recognition is key to prevent reversible complications. Imaging is essential in diagnosing and managing CNS vascular malformations. It guides treatment, tracks progress, and predicts outcomes. Modalities like the magnetic resonance imaging, computed tomography angiography, and digital subtraction angiography help to differentiate different lesion types. This table shows the key findings on neuroimaging with the different forms of CNS vascular malformations, like the presence of the flow void in arteriovenous malformations on MRI, and the presence of the nidus, which is visible on the computed tomography angiography. Then the popcorn appearance with hemosiderin rim seen in cavernomas. Then the capillary medusae pattern seen on venous malformations. Now we'll talk about some of the common vascular malformations of the CNS that are seen in clinical practice. The venous malformations are most commonly found are also known as the venous angiomas or varices, are congenital low anomalies made up of entirely of abnormal thin walled veins. These veins may appear straight, curvilinear, or rarely sessoid, often forming dense clusters. Histologically, they are arranged radially around a central nidus with a single endothelial lining and a discontinuous fibromuscular layer. They lack arterial components, an important diagnostic feature, and preserve intervening brain tissue. Additionally, additional features may include hyaline thickening, thrombosis, and inflammation, but not calcification, gliosis, or hemosiderin deposits. Venous malformations are commonly found in the supratentorial region, especially near cortical or epidermal surfaces, and less frequently in the cerebellum. They often occur where superficial and deep venous system meets. Clinically, they may be associated with Klippel-Trenaunay syndrome and intravascular coagulopathy, characterized by elevated D-dimer, low fibrinogen, and mild thrombocytopenia, with normal bone-to-beat time and partial thromboplastin time. The clinical manifestation of venous malformations vary. They are often asymptomatic and discovered incidentally. When symptomatic, they typically present with headaches or seizures, especially if located near the cortex. Rarely, infratentorial lesions can cause sensorineural hearing loss or facial paresis due to involvement of the cranial nerves 7 and 8. Larger or structurally fragile malformations carry a risk of hemorrhage. When evaluating these vascular lesions, angiographic and scintigraphic studies often reveal a distinctive medusa-like configuration characterized by large confluent medullary veins. Interestingly, the capillary and arterial faces are typically unremarkable, and the lesion may show no arterial involvement at all. Accurate diagnosis requires a comprehensive approach, integrating anatomical details with both angiographic and scintigraphic findings, to reliably distinguish these lesions from other vascular malformations. This is brain MRI showing the medusa-like pattern of these veins. Now we talk about arteriovenous malformations. These are defined by the presence of a nidus, a tangled network of dilated dysplastic vessels that form a direct connections between arteries and veins, bypassing the normal capillary bed. This creates a high flow, low resistance shunt, resulting in turbulent blood flow. Arterial feeders commonly arise from branches of the internal carotid artery, vertebrobasilar and external carotid arteries, including vessels like the middle and posterior meningeal arteries. Venous drainage may involve both superficial and deep systems, with the draining veins often appearing arterialized due to the abnormal hemodynamics. This unique vascular architecture accounts for the complexity and high-risk nature of arteriovenous malformations, making them a significant contributor to hemorrhagic stroke and neurological morbidity in affected patients. Arteriovenous malformations account for approximately 2 to 20% of all cerebrovascular malformations and are regarded as the most complex subtype. They are the most commonly encountered cerebrovascular malformations within both the brain and the spinal cord, with an autopsy prevalence ranging from 0.2% to 0.6%. Intracranial arteriovenous malformations are predominantly located in the supratentorial compartment, especially within the middle cerebral artery territory. About 18 to 25% are found in the posterior fossa, while deep-seated regions like the basal ganglia and internal capsule contribute to another 18 to 20% of cases. In the spinal cord, AVMs can involve all anatomical layers: the epidural, intradural, subpial, and intramedullary, highlighting their diverse and often challenging presentations. Most arteriovenous malformations are sporadic, accounting for about 95% of cases, and are driven by somatic mutations in genes such as the KRAS. A smaller subset, around 5%, are familial, usually inherited in an autosomal dominant pattern, with NRAS mutations sometimes implicated. Several risk factors have been associated with arteriovenous malformation development, including prior intracranial hemorrhage, head trauma, moya disease, epilepsy, and exposure to radiation therapy. Understanding both genetic mutations and environmental influences involved is essential for advancing our knowledge of arteriovenous malformation pathogenesis and exploring potential targeted therapeutic approaches. In arteriovenous malformations, arterial blood is shunted directly into the venous system without passing through capillaries. This abnormal circuit leads to venous hypertension and tissue hypoxia, a process known as the Steele phenomenon, where blood is diverted away from healthy brain tissue. In excessive or slow flow arteriovenous malformation, this can place significant strain on the cerebrovascular system, potentially resulting in high output cardiac failure. Clinically, patients with arteriovenous malformations are at risk of intracranial hemorrhages, seizures, mass effect, focal ischemia due to hypoperfusion, and in severe cases, cardiac failure, especially when the lesions are large or deeply seated. Diagnosing arteriovenous malformations requires a multimodal imaging approach to assess both anatomy and hemodynamics. Ultrasound and Doppler may reveal anechoic tubular structure with tubular high-velocity, low-resistance flow and arterialized veins, especially used in neonates or superficial lesions. Magnetic resonance imaging, particularly T2-weighted sequences, shows characteristic flow voids from rapidly flowing blood, dilated veins, and often perilesional edema. 4D magnetic resonance angiography offers a dynamic visualization of feeding arteries, the nidus, and the draining veins, helping to estimate lesion size and its physiological impact. Digital subtraction angiography remains the gold standard, allowing detailed visualization of the central nidus, early venous drainage, and precise vascular mapping. Digital subtraction angiography is also critical for differentiating arteriovenous malformations from similar lesions like Cavernous angiomas. This is the MRI. This is T2 imaging showing the flow void in arteriovenous malformation. This is T2 with contrast, and then this is digital subtraction angiography showing the nidus. Management of arteriovenous malformations is highly individualized and depends on factors such as lesion size, location, venous drainage pattern, and overall complexity. The main treatment options include microsurgical resection, which is preferred for superficial arteriovenous malformations less than 6 cm in size, particularly when there is no deep venous drainage. These lesions are more accessible allowing for safer and more complete removal with a lower risk of neurological injury. Stereostatic radiosurgery is most effective for small arteriovenous malformations under 3 cm, with arbitration rate ranging from 59 to 68%. It is a minimally invasive option, though delayed, and carries risks such as radiation-induced edema and rarely radionecrosis. Pretreatment sclerotherapy can improve outcome. Endovascular embolization is primarily an adjunctive therapy used to reduce nodule size and vascular flow prior to surgery or stereostatic radiosurgery. On its own, it is rarely curative and carries a high risk of recurrence. A multimodal approach combining embolization with surgery or radiosurgery can optimize treatment outcomes. However, embolization-induced tissue hypoxia may stimulate angiogenesis and increase the risk of recurrence if not followed by definitive therapy. Now we'll talk about cavernomas, which is also called cavernous venous malformations. These are solitary, well-circumscribed, non-encapsulated lesions with a characteristic mole-bearing-like appearance. They range in size from a few millimeters to several centimeters and lack arterial feeders or draining veins. Histologically, they consist of large blood-filled vascular spaces lined by a single layer of endothelium, separated by fibrous septa without intervening brain tissue. The vessel walls are thin, lacking smooth muscle and elastic layers. Commonly associated findings include thrombosis, hyalinization, calcification, hemocytic deposits, gliosis, and macrophage infiltration. Cavernomas can occur in both intracranial and spinal locations. Intracranially, they are commonly found in the subcortical white matter pons, basal ganglia, and cerebellum, and rarely in the third ventricle or dura. Spinal lesions may involve the vertebral bodies, epidural, intradural, and rarely intramedullary spaces. They may present as solitary or multiple lesions, especially in familial cases or in association with liver involvement. So cavernomas may arise from or contain telangiectasias, or they can coexist with arteriovenous malformations or evolve from them. Cavernomas can be sporadic, typically presented as a single lesion with no family history, or familial, following an autosomal dominant pattern. Familial cases are linked with mutations in certain genes, and the familial cases are further classified into cerebral cavernomas malformation, cavernomas type 1, type 2, and type 3. The type 1 is associated with mutations in the gene KRIT1 gene, that is the Krepf interaction trapped 1 gene, while the type 2 with Cavani gene. Type 3 is mutation in the programmed cell death 10. These genes encode the cerebral cavernous malformations protein complex, which regulate endothelial cell additions, interactions, and proliferations through signaling pathways, such as the mitogene activated protein kinase 3, Kruppel-like factor 2/4 pathway, and the RAS homolog family member A, Rho-associated coil containing protein kinase pathway. This is the MRI showing a cavernoma in the temporal lobe with hemorrhage ring, which is this hypointensity here. Cavernomas are typically angiographically occult, lacking visible feeding arteries or draining veins. MRI is the first line imaging with susceptibility weighted imaging, offering high sensitivity for detecting deoxyhemoglobin and hemosiderin. Gradient record echo MRI is a useful second line tool but may overestimate lesion size due to the blooming artifact. T1 and T2 MRI sequences are better suited for accurate lesion size estimation after diagnosis. While the digital subtraction angiography is non-diagnostic, it can help to differentiate cavernomas from arteriovenous malformations when necessary. Treatment of cerebral cavernomas depends on symptoms and the characteristics of the lesion. Conservative management is preferred for asymptomatic or minimally symptomatic cases, with MRI monitoring and anti-epileptic drugs if seizures are present. Anticoagulants are generally avoided due to risk of bleeding. Microsurgical resection is the treatment of choice for symptomatic hemorrhage, drug-resistant seizures, or accessible superficial lesions, though the risk increases with deep or eloquent brain areas. Stereotactic radiosurgery is reserved for deep or high-risk lesions not amenable to surgery. While it is less effective than in arteriovenous malformation and has a delayed effect, it can help reduce hemorrhagic risk. In conclusion, CNS vascular malformations are a diverse group of developmental anomalies classified by their structure and location. While some remain asymptomatic, others can lead to serious complications like spontaneous intracerebral hemorrhage, progressive neurological deficit, or vascular steal syndromes. A solid understanding of their embryologic origin, anatomical characteristics, and clinical behavior is essential for accurate diagnostic and effective management. These are my selected references. Thank you for listening.